I'm going to talk today about chest tubes. First we're going to start with some different things that can cause a need for a chest tube. I'm not going to define them, but I'm going to give you causes. The first one is a pleural effusion. Pneumonia or systemic lupus can cause the need for a chest tube. Hemothorax, you can have your blunt chest trauma or a penetrating trauma to the chest. A pneumothorax, sometimes you can have a spontaneous pneumothorax or it can be caused by blunt chest trauma. Insertion of a central venous access line can cause that, and also mechanical ventilation with like an ambu bag or setting your PEEP too high can cause the collapse and need. Empyema, pulmonary infection, lung abscess, and infected pleural effusion. Attention pneumo, it can be blunt chest trauma again, and it's very rapidly developing and life-threatening. Then there's thoracic surgery, and that's just from being in the thoracic cavity, changing that pressure. If you need to, you'll need to look at your A&P book to review like physiology of ventilation and the intra versus extra pressures. Some signs and symptoms that a chest tube is necessary. You can have tracheal deviation, respiratory distress, jugular vein distension, asymmetrical chest rise, absence of breath sounds on one side. So maybe on the left side you can hear it, but on the right there are no lung sounds. X-ray is a true evaluation of a pneumo because you can have a partial, a complete. The definition of the chest tube placement, it's a drain placed in the pleural space to restore intrapleural pressure. It allows for a re-expansion of the lung. It's placed in, now, there's two different ways. One is mid-clavicular fifth intercostal space, but new studies have shown that they're going fifth intercostal space, mid-axillary line is where they're actually inserting that. This is inserted either by a surgeon or maybe a trauma doctor or an ER doctor that's had training in that. They used to have a 3-bottle system. I've never seen that. Pretty much places are doing what's called a pleural vac, and I'll show you that and we'll go through that. And that's a commercial type system. When a chest tube is initially put in, it should be evaluated and the patient should be evaluated every hour. There will be an occlusive dressing of some kind. Usually it's like an op-site, and they cover like an ABD, and then sometimes there's even tape. We have some 3M surgical tape that'll be placed over top of that. And it's very important that this occlusive dressing stays intact. If at any time it doesn't, you need to have the supplies in the room to immediately put pressure on and cover that and get an RN in immediately. Things that we assess when a patient has a chest tube. We need to assess lung sounds, respiratory status, and know their baseline. What is their baseline, and are they deviating from that at all? Signs and symptoms of cardiac tamponade. Is the dressing dry and intact? Are they leaking around this dressing? Is there crepitus if you touch around this dressing? Those are signs that the doctor needs to be notified immediately. Are all of the tubes free of kinks? You don't want any kinking. You want the suction to be hooked on properly. Clamps, if there's any clamps, they need to be open. We need to look at the amount of drainage, how much they're putting out. When we're first doing it hourly, then you need to document hourly how much drainage there's coming from that chest tube. And on the chest tube, there's three spots on this. The first one is the suction control chamber, and water is filled here to a minus 20 centimeters. This is the water seal chamber, and it's filled to 2 centimeter level. And this is for your drainage. And if you look, there's different measurements. It starts here with 50, and it works its way up to 1700. One article that I found said that if you're having over 100 cc's an hour, that you need to notify the physician immediately as to the drainage. If the drainage stops suddenly, follow your tubes and make sure that your tubes are not kinked or bent over, the patient's not laying on them. This one is hooked to the suction. And the longer one will be hooked to your patient, and it's longer because it gives them some more room for the patient to move and roll over and things of that nature. You can have some gentle bubbling in the suction is okay, but continuous bubbling in the water seal is not okay. What the water seal does is it allows for air to go out of the chest cavity when the patient exhales, but when they inhale, it stops it and doesn't allow for air to go into the cavity, and we don't want air to be going into that thoracic cavity. So if there's continuous bubbling on here, then it's something that gets assessed. Initially what the nurse will do, and this would be the RN, will take a padded clamp and they will clamp it closest to the dressing. If it stops leaking, then there's something with the chest tube. If it continues to leak, then it's somewhere from where you clamped it down to the machine. Either there's a hole in the tubing, or the tubing's broke, or there's something wrong with the machine. Let me see. With the patient, some hospital policies will say after the first 24 hours of the patient having a chest tube, then it can be the I and O of the drainage can be every 8 hours. You need to follow what your policy states on that. Some patients will need oxygen to help with dyspnea. Some patients will be fine without oxygen. Each patient's going to vary in how severe. Some patients have other things like COPD and CHF and other conditions that are going to cause them maybe tumors in the lungs and things like that where they're going to need oxygen. And so that can, impaired gas exchange is a huge nursing diagnosis, and also acute pain. These chest tubes are not comfortable for the patient, and pain management is huge. Recommendation is IV versus IM for pain management. Some patients receive PCAs, but you need to continuously be assessing pain management with that patient. So when you come into the patient's room, you need to make sure that this is in an upright position. This should not be laying down or tipped onto its side at all times. This needs to be in an upright position. So some of them have hooks where they'll hook onto the bed. Some of them have a flat bottom so that they'll be standing upright. So the first thing you want to do when you walk into the room is assess and make sure that that's standing up. You'll introduce yourself to your patient. You'll say, "Hi, my name is Isadora, and I'm one of the nursing instructors here at Calmar, and I'll be taking care of you today with my nursing student." Ask her if she's having any pain, and while you're doing that, you're looking at her. Is she gasping? How's her color? We're doing that assessment for respiratory distress, and that's huge. And Mrs. Smith is nice and pink. She's breathing normal. It's not labored. She's not grunting. I don't hear any wheezing. I can do a pulse ox and make sure that she's maintaining an adequate pulse ox. The physician might order greater than 92% or 90%. I want to make sure that she's doing that. I'm going to assess her lungs, and I'm going to assess in all fields. I want to make sure that I'm hearing lung sounds in all fields, and this is very crucial. When you reposition this patient and you go to sit them up, make sure that you give yourself plenty of tubing, so when you set them up, you're not hooking that tubing on the bed and pull this chest tube out. Nothing worse than pulling out a chest tube. The patient will be unhappy and the physician will be unhappy. So you can reposition them. They might be better to roll away from their side for lung sounds. We're just going to have to base it on how the patient is. So once you've done your assessment of your lung sounds, you can look at your suction and make sure that your suction canister is on. The suction canister, what actually determines how much suction is being pulled out of that chest tube, is where the water level is filled. And it states that minus 20 centimeters is for an average adult. If it's a pediatric patient or maybe an elderly patient, the doctor might do less suctioning for that. So you would have to look in the charting as to what the physician wrote for that placement. Now, nurses do help when these are inserted with filling them appropriately with water and setting up the sterile field and helping the doctor. So again, just review any anatomy that you need to and definitions of the things that can cause the need for a chest tube.
Gastric irritation
And that's it.
administered with meals.